Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Welcome to the Deep Dive. Today we're going to unpack a condition with, well, a really intricate name and an equally complex nature. Vogt-Koyanagi-Harada disease.
Right, VKH for short, maybe.
Definitely VKH. So imagine this mysterious illness. It can threaten your vision quite severely, but it doesn't actually stop there.
No, it's really an enigma. It reaches beyond the eyes, affecting the brain, the ears, even your skin and hair. It's a real multi-system puzzle.
And we're here today to help you understand it.
That's right. So at its core, VKH is a rare autoimmune disorder. The body's immune system basically attacks itself.
And it causes this widespread inflammation, mainly primarily in the eyes.
Primarily in the eyes, yes, but it also hits the central nervous system, the inner ear, and what we call the integumentary system, so skin and hair.
And the potential for, really significant vision loss makes it something we absolutely need to understand better.
Definitely.
So our mission today is to demystify VKH for you. We'll trace its kind of surprising history, explore exactly how it works in the body.
Look at how doctors diagnose it now, using some pretty cutting-edge tools.
Right, and reveal the treatments that are, honestly, transforming outcomes for patients. The goal is to give you a really comprehensive but clear understanding, a shortcut, if you will, to being properly informed about VKH.
And we should mention, our insights today are drawn largely from a detailed research review paper covering VKH's immunopathogenesis, diagnosis, management, and we've pulled in some supporting sources too.
Okay, so we've set the stage. This condition is complex, it's multi-system. Let's really pull back the curtain now. What exactly is VKH doing inside the body?
Well, at its most basic level, it's causing inflammation, widespread inflammation affecting both eyes.
Specifically in the uveal tract. That's the eye's middle pigmented layer.
Exactly, the uvea.
Yeah.
But like we said, it's definitely not just about the eyes.
Yeah.
What really defines VKH is this multi-system aspect. It specifically targets organs containing melanocytes.
Ah, the pigment cells.
The pigment cells, precisely. So, yeah, beyond the eyes, you see it affect the meninges, those membranes around the brain and spinal cord.
Okay.
The inner ear, and of course the skin and hair. Now, in the eye itself, the main problem is this deep, non-infectious sort of granulomatous inflammation of the uvea.
Granulomatous meaning clusters of inflammatory cells.
Right. And this causes the uvea to thicken, especially the choroid. That's the layer rich in blood vessels behind the retina. And that thickening, well, that's the key driver of potential vision loss.
It's quite a name, Vogt-Koyanagi-Harada. How did we even arrive at that? It sounds like multiple people involved over time.
It really is. It's a mosaic of discoveries from the early 20th century. It started with Alfred Vogt, a Swiss ophthalmologist, back in 1906.
Okay.
He was the first to formally document cases with inflammation in both eyes, but also with poliosis, the whitening of eyelashes.
Right. And then Koyanagi.
Yoshizo Koyanagi from Japan in 1926. He described cases that had serous retinal detachments, that's fluid buildup under the retina in both eyes. And he noted an increase in inflammatory cells in the cerebrospinal fluid, the CSF.
Interesting. And Harada.
Inosuke Harada, also Japanese, in 1929. He gave these really detailed accounts, focusing more on the back of the eye, the posterior segment, and those skin and hair changes Vogt mentioned.
So initially they thought these might be separate things, like Vogt-Koyanagi disease for the front of the eye and skin, and Harada's for the back of the eye and the neurological stuff?
Exactly. That was the initial logical distinction, Vogt-Koyanagi disease and Harada's disease.
But then came this, you called it a conceptual leap?
Yes. Because despite those different presentations, the medical community eventually realized, wait, these aren't separate entities. They're different facets of a single underlying problem.
Ah, targeting those melanocytes everywhere.
Precisely. So they unified it into Vogt-Koyanagi-Harada syndrome, recognizing one core pathophysiology. And this is actually really insightful, because even today, a patient might only show, say, the eye symptoms and the neurological ones, or maybe just the eye and skin signs. That unified concept is crucial for diagnosis now.
And why does understanding this matter so much?
Well, VKH is a really significant cause of vision loss from non-infectious uveitis, especially as we'll see in certain populations with genetic links.
And because it hits so many systems.
You absolutely need a team approach. Ophthalmologists working with neurologists, rheumatologists, dermatologists sometimes. Collaboration is key.
And the urgency you mentioned, getting that diagnosis right and starting treatment quickly, it's about saving sight, isn't it?
It absolutely is. Preventing severe, irreversible vision loss is paramount. And really, the core message from the research is this. VKH is an autoimmune attack on pigment cells, driven by T cells, strongly linked to genetics. And the key to good outcomes: early, aggressive, and sustained immunomodulatory therapy, calming that immune system down properly.
Okay, so who is most susceptible? Let's talk epidemiology. You mentioned it's rare overall.
Yeah, relatively rare globally. Maybe 1 in 400,000 people per year. But here's what's really striking. It has a strong predilection for individuals with more darkly pigmented skin.
So we see it much more in certain ethnic groups.
Definitely. It's most prevalent in people of Asian descent, especially Japanese, Hispanic, Native American, Middle Eastern, and Asian Indian populations. In referral centers in these regions, VKH can account for a pretty significant chunk of uveitis cases, sometimes, 7% up to maybe 22%.
Wow, that's quite high for a rare disease and less common elsewhere.
Much rarer in Caucasians and even rarer in people of sub-Saharan African descent. It's quite a stark difference. You even see this reflected in immigration studies, like one in France found most VKH cases were in patients originally from North Africa or Southeast Asia.
What about age and gender?
It typically hits young to middle-aged adults. The peak is usually between 20 and 50 years old.
But not exclusively.
No, it can happen at the extremes. We see cases in children even as young as 3, and also in older geriatric patients.
And does it behave differently in kids?
It seems to. Pediatric cases often tend to be more aggressive, more drawn out, and unfortunately associated with more complications down the line, like scarring under the retina.
And gender?
Generally, there's a female predominance. Roughly the 2-to-1 female-to-male ratio is often cited,
Okay.
though there might be some geographic variations. Some reports, for instance from Japan, have occasionally indicated higher proportions in males, but overall more common in women.
These ethnic patterns are really pronounced. Does that point directly to a genetic component?
Oh, absolutely. That's one of the most fascinating aspects. The link between these ethnic disparities in genetics is, well, it's undeniable. It involved our HLA genes.
HLA. Those are the genes involved in how our immune system recognizes self versus non-self, right? Presenting antigens.
Exactly. They present little protein fragments, antigens, to our T cells, which, as we said, orchestrate the immune response if the wrong antigen gets presented or presented incorrectly.
The T cells might mistake the body's own cells for invaders.
Precisely. And in VKH, the most significant genetic link is with HLA-DR4, specifically a subtype called HLA-DRB10405.
And that subtype is common in East Asian populations.
Highly prevalent, yes, which directly mirrors the higher rates of VKH we see there. There are a few other HLA types implicated too, like HLA-DRW53.
So the genetics really explains the epidemiology. The idea is that this specific HLA variant is maybe better at grabbing onto bits of melanocyte protein.
Right, like proteins from the tyrosinase family involved in making pigment.
And showing them to T cells that shouldn't be reacting. Or maybe it's bad at clearing out those self-reactive T cells during development.
That's the hypothesis, yes. Either way, it makes individuals with that genetic makeup much more vulnerable to developing VKH if something triggers it.
Okay, so genetics is the fuel. What about the spark? What actually sets off this autoimmune attack?
Well, the general consensus scientifically is that VKH is this faulty T cell response attacking the body's own melanocytes. When you look at biopsies from affected tissues,
You see the evidence.
you see infiltration by lymphocytes, these specialized immune cells called epithelioid cells, multinucleated giant cells. These are the hallmarks of that granulomatous inflammation we mentioned.
And the main culprits are CD4 plus T helper cells.
They seem to be the primary orchestrators, yes. The thinking is that maybe T regulatory cells, or TREGs, the ones that normally put the brakes on the immune system and prevent autoimmunity, maybe they're deficient or not working properly in VKH, that allows these self-reactive T cells to kind of run rampant.
And what exactly are these T cells targeting on the melanocytes? What are the specific antigens?
Research has pinpointed specific targets. Key ones are proteins from the tyrosinase family essential for making melanin pigment, and another protein called GP100.
And the inflammation itself, it involves different chemical signals, cytokines.
Right, it's a complex interplay. both Th1 and Th17 pathways. Different flavors of T helper cell responses seem to be involved.
But the Th17 pathway is getting a lot of attention now.
It really is. This pathway produces a very pro-inflammatory cytokine called interleukin-17, or IL-17. And here's the key finding. Patients with active VKH have elevated levels of IL-17 and more Th17 cells circulating.
And less of the calming signals.
Exactly.
Yeah.
At the same time, they often have reduced levels of anti-inflammatory cytokine, interleukin-27. So you have this imbalance, too much go signal for inflammation, not enough stop signal. This seems critical for driving the inflammation inside the eye.
And there's even a genetic link there, too.
Yes. Studies have linked VKH risk to variations in the gene for the IL-23 receptor, IL-23R. And IL-23 is a cytokine that promotes the development of these Th17 cells. So it all starts to tie together.
Okay, genetics provides the susceptibility, the immune system imbalance drives the inflammation, but what's the initial trigger, the spark for this fire?
That's still a bit of a mystery, but a viral infection is the strongest suspect.
Because of that flu-like prodromal phase.
Precisely. The fever, headache, meningismus, it really mimics a viral illness. Though no single virus has been definitively proven as the cause, Epstein-Barr virus, EBV, and cytomegalovirus, CMV, are often proposed as potential culprits.
Through molecular mimicry.
That's the leading hypothesis. The idea is that some part of the virus, an antigen, looks structurally very similar to a self-antigen on the melanocytes. So, the immune system mounts a response against the virus, but then those activated T cells mistakenly cross-react and attack the body's own pigment cells.
Like a case of mistaken identity by the immune system.
Essentially, yes. Other potential triggers have been suggested too, like physical trauma, especially penetrating eye injuries.
Which can cause that condition, sympathetic ophthalmia, almost identical to VKH.
Exactly. Also sometimes significant skin wounds or even certain medical treatments like BCG immunotherapy for bladder cancer.
So, pulling this all together, how does this underlying pathology, this attack on melanocytes, explain the wide range of symptoms we see?
It maps surprisingly well, actually. The location of melanocytes throughout the body directly correlates with the clinical signs.
Okay, walk us through that.
So, melanocytes in the uvea and the retinal pigment epithelium, the RPE layer, attacking those causes the pain of uveitis, the inflammation throughout the eye. It causes the breakdown of the RPE barrier, leading to those serous retinal detachments in the acute phase.
And later on?
Later, the destruction of these cells leads to that depigmentation, the characteristic sunset glow fundus you see in the convalescent stage.
Makes sense. What about the ears?
Melanocytes are also found in the inner ear. Attacking them leads to the auditory symptoms tinnitus, that ringing sound, and sensorineural hearing loss.
And skin and hair?
Same principle. Targeting melanocytes in the skin and hair follicles causes vitiligo, patches of white skin, poliosis, white patches of hair or lashes, and alopecia hair loss.
And the neurological symptoms, the headaches and meningitis signs in the beginning?
That's linked to melanocytes found in the leptomeninges, the membranes covering the brain and spinal cord. Attacking those causes inflammation there, leading to aseptic meningitis.
So it's really not random. It's a predictable pattern based on where these target cells are located.
Exactly. It shows VKH as a systemic consequence of one specific autoimmune process. And recognizing that pattern, especially the extraocular signs, is crucial for distinguishing VKH from uveitis that only affects the eye.
Let's talk about the clinical journey then. You mentioned 4 stages.
That's the classic description, yes. 4 distinct, though sometimes overlapping, stages. Prodromal, acute uveitic, convalescent, and chronic recurrent.
And the goal of treatment is always to suppress inflammation whenever it's active, but understanding the stage helps predict what might happen next.
Precisely. It guides diagnosis and gives clues about prognosis.
Okay, let's break them down. Stage 1, prodromal.
Right, the prodromal or meningeal stage. This lasts just days, maybe up to a couple of weeks. And like we said, it often looks like a nonspecific viral illness, which makes early diagnosis really tough.
So symptoms are mainly neurological or auditory then?
Yes. Severe headache is very common, often fever, neck stiffness, that's meningismus, maybe sensitivity to light. A key diagnostic finding here, if you do a lumbar puncture, is lymphocytic pleocytosis in the cerebrospinal fluid. Basically, increased white blood cells in the CSF, seen in over 80% of patients at this stage.
And the auditory symptoms?
Tinnitus, vertigo or dizziness, and often high-frequency sensorineural hearing loss. Ocular symptoms might be minimal at this point, maybe just some pain around the eyes, light sensitivity, or sometimes this weird scalp or skin hypersensitivity.
Then comes stage 2, Acute uveitic.
The acute uveitic or ophthalmologic stage. This usually kicks in days to weeks after the prodromal symptoms and can last for weeks if it's not treated. This is typically when patients seek medical attention because the main symptom is sudden bilateral blurring of vision.
Bilateral, meaning both eyes.
Usually both eyes, yes, though it can sometimes start more severely in one than the other, often accompanied by eye pain and redness.
And what's happening inside the eye?
This is where we see the hallmark signs. In the posterior segment, the back of the eye, there's severe, diffuse, granulomatous pandivitis inflammation everywhere. The choroid becomes massively thickened. You often see optic disc swelling. And crucially, those multifocal, bullous, serious retinal detachments.
The fluid blisters under the retina, you said that's pathognomic.
Highly characteristic, yes.
Yeah.
It's due to that RPE barrier breaking down from the intense inflammation. In the anterior segment, the front of the eye, you get iridocyclitis inflammation of the iris and ciliary body. Initially, it might look non-granulomous, but it can evolve to show those mutton fat KPs, those greasy-looking inflammatory deposits on the cornea.
And a potential complication here.
A serious acute one is angle closure glaucoma. The swelling of the ciliary body can push the iris forward, blocking fluid drainage and causing a sudden spike in eye pressure. Needs urgent attention.
Okay, after the acute storm comes stage 3.
Right, the convalescent or chronic stage. This starts weeks to months after the acute phase and can last for many months, even years. It's characterized by the gradual resolution of active inflammation, but also progressive depigmentation as those melanocytes are destroyed.
So this is when the skin and hair changes really show up.
Exactly. The classic dermatological signs become apparent. Vitiligo, poliosis, alopecia. And these are typically permanent changes.
And in the eye.
You see that diffuse depigmentation of the choroid and RPE create that classic orange-red sunset glow fundus. It really does look like a sunset inside the eye. Other signs might include paralimbal vitiligo, known as Segura's sign, especially common in Japanese patients, and maybe some depigmented scars in the retina.
And finally, stage 4, chronic recurrent.
The chronic recurrent states. This isn't inevitable, but it can interrupt the convalescence stage, often popping up maybe 6 to 9 months after the initial illness. And it's strongly associated with stopping corticosteroids too early or tapering them too quickly.
High risk of relapse, then.
Very high. Over 50% within 6 months in some studies if treatment is inadequate initially. Interestingly, these recurrences typically manifest as granulomatous anterior uveitis inflammation, mainly in the front of the eye. Recurrent posterior uveitis with new retinal detachments is actually uncommon if that initial acute phase was hit hard with treatment.
But this is where long-term problems arise.
Yes, unfortunately. The majority of vision-threatening complications tend to develop during this chronic recurrent phase. Things like cataracts, glaucoma, subretinal fibrosis or scarring, and choroidal neovascularization, abnormal blood vessel growth.
Okay, that's a clear progression. So how do doctors actually pin down the diagnosis? You mentioned criteria.
Yes, the diagnosis is primarily clinical, meaning based on the signs and symptoms, but is guided by the Revised Diagnostic Criteria, or RDC, published back in 2001 to standardize things.
And there are key exclusions first.
Absolutely crucial. 2 main ones. First, no history of penetrating ocular trauma or surgery before the uveitis started. This is vital to rule out sympathetic ophthalmia, which looks almost identical but has that specific injury trigger.
Okay.
Second, no clinical or laboratory evidence pointing to other diseases that could mimic VKH. You have to rule out the imposters.
Once those are cleared, the RDC has categories.
Right. It classifies VKH based on the pattern of systemic involvement, complete VKH. You need the characteristic bilateral eye findings plus neurological or auditory findings plus integumentary skin hair findings. All 3 systems involved besides the eyes. Incomplete VKH. Bilateral eye findings plus either neurological, auditory, or integumentary findings, but not both. Probable VKH. This is for cases with just the characteristic bilateral eye inflammation, but no definite extraocular signs yet.
And you stressed how vital it is to differentiate VKH from other conditions.
Absolutely critical, because the main treatment involves potent immunosuppression. You absolutely cannot afford to misdiagnose, say, an infection is VKH and give steroids. That could be catastrophic.
So what are the main conditions to rule out?
Well, sympathetic ophthalmia is top of the list, clinically and pathologically almost identical. The only real differentiator is that history of prior eye injury or surgery.
Okay.
Then you have infectious uveitis, especially things like syphilis and tuberculosis. You need specific blood tests like VDR or LRPR for syphilis, or other tests like a chest x-ray or TB skin blood test to rule these out definitively.
others?
Sarcoidosis can look similar, but often has lung involvement, like large lymph nodes on chest X-ray, and specific retinal signs like candle wax drippings. And primary intraocular lymphoma, a type of cancer, can masquerade as chronic inflammation, especially in older adults. It often doesn't respond well to steroids initially and needs a biopsy for diagnosis.
Let's talk about the imaging tools. You said they're indispensable now.
Completely. Modern ocular imaging lets us objectively see the pathology, confirm inflammation even if it's subtle, and monitor how well treatment is working.
Like fluorescein angiography, FA.
Right. In the acute stage of VKH, FA shows a classic pattern, often called stars at night. You see these early pinpoint spots of hyperfluorescence, bright dots, where dye is leaking from the RPE that gradually enlarge and pool. You also typically see leakage from the optic disc. It highlights that breakdown of the RPE barrier.
And indocyanine green angiography, ICGA, you said that's even better for the choroid.
Yes, ICGA uses a different dye that visualizes the deeper choroidal circulation much better. It's extremely sensitive for active VKH choroiditis, maybe close to 100% in active disease.
What does it show?
In the acute phase, it shows delayed filling of the choroidal vessels, and very importantly, numerous hypofluorescent dark dots. These dots correspond to the granulomas, those clusters of inflammatory cells within the choroidal stroma. Often, ICGA reveals many more of these dark dots than clinically visible lesions, really confirming the BCA nature of the choroiditis. It's critical.
Yeah, OCT, optical coherence tomography.
OCT, and especially enhanced depth imaging OCT, or EDI OCT, are also vital. Standard OCT is great for detecting and measuring that subretinal fluid, and it often shows these characteristic fibrinous, hyperreflective septa within the fluid. It also clearly shows disruption of the outer retinal layers, like the ellipsoid zone, which indicates photoreceptor damage and correlates with vision loss.
And the enhanced depth version, EDI-OCT.
EDI-CT is specifically designed to get better images of the deeper choroid. Its game-changing contribution is quantifying that massive choroidal thickening in the acute phase. We can literally measure how thick the choroid is.
Then track it over time?
Exactly. As treatment works, the choroidal thickness decreases, providing an objective measure of response. EDI-OCT also documents the choroidal thinning and atrophy that could occur in the chronic phase.
You mentioned earlier this shift in diagnosis from waiting for late signs.
Right. Historically, diagnosis often relied on seeing the late-stage depigmentation, the vitiligo, the sunset glow fundus. But the treatment goal now is prevention of that damage.
So good treatment meant patients might never develop the full picture needed for the old diagnostic approach. A paradox.
Exactly. But advanced imaging, especially ICGA, showing those early dark dots, and EDI-OCT, showing that immediate choroidal thickening, resolves this paradox. It lets us see the core pathology, the choroiditis, right at the beginning. This allows intervention within that critical therapeutic window of opportunity before irreversible damage occurs. It's a huge step forward.
Are there other useful tests, systemic ones?
A lumbar puncture to analyze the cerebrospinal fluid, or CSF, can be very helpful, especially in the prodromal or early acute phase. Finding that lymphocytic pleocytosis, the increased white cells, supports the diagnosis and fulfills one of the neurologic criteria. It is usually temporary, though.
Okay.
And formal auditory testing, audiometry, can objectively document any sensory or neural hearing loss, fulfilling an auditory criterion.
Okay, let's move on to fighting back. How is VKH treated? What are the core principles?
The absolute cornerstone is rapid and potent suppression of that intense intraocular inflammation. The goal is to prevent permanent structural damage to the eye.
And timing is key.
Critical. There's a strong consensus. Early and aggressive treatment leads to significantly better long-term visual outcomes and, crucially, helps prevent the disease from settling into that chronic recurrent pattern.
And it needs to be sustained.
Yes, absolutely. This isn't a short course of treatment. Immunosuppression needs to be sustained with a very slow, gradual taper of the medications. Over many months, we're talking at least 6 to 9 months, often longer, to prevent the inflammation from flaring back up.
What's the first line of attack?
Systemic corticosteroids are the undisputed mainstay. High-dose steroids. They're extremely effective at quenching severe inflammation and usually lead to prompt resolution of those serious retinal detachments.
How are they given?
Typically initiated with high doses oral prednisone, maybe 1 to 1.5 milligrams per kilogram per day, or sometimes even intravenous pulse methylprednisolone for very severe cases or rapid vision loss.
And the taper have to be slow?
Extremely slow. That's probably one of the most critical aspects of management. Tapering over 6, 9, even 12 months or more. Tapering too quickly is a major, major risk factor for relapse and progression to chronic disease.
But steroids have downsides, right? Especially long-term.
They absolutely do. That's the major challenge. Long-term corticosteroid use comes with a whole host of significant side effects.
Ocular ones.
Ocular side effects include posterior subcapsular cataracts and steroid-induced glaucoma, increased eye pressure.
And systemic effects.
Systemically, the list is long. Hyperglycemia, potentially triggering or worsening diabetes, weight gain, coachingoid features like moon face, buffalo hump, hypertension, osteoporosis, thinning bones, mood changes, increased susceptibility to infections. It's a significant burden.
And that burden is why doctors look for other options. Steroid-sparing agents.
Exactly. Those side effects are the primary motivation for using steroid-sparing immunomodulatory therapy, or IMT. And there's been a real paradigm shift here. Historically, IMTs were sort of held in reserve, used only if steroids failed or caused unacceptable side effects. But now there's growing and quite strong evidence supporting the early initiation of IMT alongside corticosteroids right from the start as first-line therapy for acute initial onset VKH.
So combination therapy from day one?
Yes, for moderate to severe cases especially. This combination approach seems significantly more effective at preventing flares, preventing chronic sequelae like the sunset glow fundus, and allowing for faster steroid tapering. In fact, surveys show a majority of uveitis specialists, over 60%, now prefer this early combination strategy.
What kind of IMTs are typically used first?
The most common first-line choices are the antimetabolites. Methotrexate, MTX, and mycophenolate mofetil, MMF, are probably the two most frequently used.
How do they compare?
Studies suggest they're pretty comparable in controlling overall inflammation. Some data indicates methotrexate might be slightly better at reducing retinal thickness on OCT. Methotrexate can cause side effects like nausea, fatigue, hair thinning, mouth ulcers, and needs monitoring for liver toxicity and bone marrow suppression.
And mycophenolate.
MMF often causes gastrointestinal issues. Diarrhea, abdominal pain are common. It also requires monitoring for myelosuppression and infection risk. Other older conventional immunosuppressants like azathioprine and cyclosporine are also sometimes used, maybe as second-line IMT options.
What if those don't work? Or for very severe cases, are there stronger options?
Yes, for refractory disease, meaning it's not responding well to steroids, plus conventional IMT biologic agents offer powerful alternatives.
Like TNF-alpha inhibitors.
Exactly. Drugs like adalimumab, Humira, and infliximab, Remicade, target a key inflammatory cytokine called TNF-alpha. They're generally perceived as the most effective class of IMT for severe uveitis. Adalimumab is actually FDA approved specifically for non-infectious uveitis, including VKH potentially.
And they work well.
They can be very effective in controlling inflammation, preserving vision, and allowing patients to significantly reduce or even stop corticosteroids entirely.
But they have risks too.
They do. The main concern is a significantly increased risk of serious infections, particularly the reactivation of latent tuberculosis. So all patients absolutely must be screened for TB before starting these drugs. Other potential risks include new or worsening psoriasis, rare neurological issues, lupus-like syndromes, and a theoretical, though debated, potential long-term malignancy risk. They are powerful drugs requiring careful monitoring.
Are there even newer options for the toughest cases?
For the truly refractory cases, yes, there are emerging strategies. One approach is B-cell depletion using rituximab. This drug targets CD20, a marker on B cells, another type of immune cell.
And that helps in VKH.
Surprisingly, yes. Studies have shown it can be effective in highly refractory, chronic recurrent VKH that hasn't responded to other treatments, including TNF inhibitors. This suggests that B cells likely play a role, maybe more than previously thought, in perpetuating that chronic inflammation, at least in some patients. It opens up another avenue for these very challenging situations.
So even with these advanced treatments, complications can still happen. Let's talk about managing that fallout. Glaucoma seems common.
It is. Glaucoma is a frequent and serious complication, seen in up to maybe 45% of VKH patients over time. And it can happen in two main ways.
Okay.
First, there's acute angle closure glaucoma. This happens during the acute uveitic phase. That intense swelling of the ciliary body and choroid pushes the lens and iris forward, physically blocking the drainage angle where fluid normally leaves the eye. This causes a very rapid, painful spike in intraocular pressure.
Needs immediate treatment.
Absolutely. The second main type is open-angle glaucoma, which tends to develop later in the chronic phase. The most common cause here is actually steroid-induced glaucoma from long-term treatment. But chronic inflammation itself can also clog up the eye's natural drain, the trabecular meshwork, And sometimes posterior synechia adhesions between the iris and the lens can develop, leading to pupillary block and a secondary type of angle closure.
How is glaucoma managed in VKH?
The absolute key is aggressive control of the underlying inflammation with systemic immunosuppression. That's paramount. Beyond that, topical eye drops to lower pressure are used. Laser peripheral iridotomy might be needed if there's pupillary block. Glaucoma surgery, like a trabeculectomy, is usually reserved as a last resort and should only be done when the eye inflammation is completely quiet for several months. Surgery in an inflamed eye is very risky.
Cataracts are also very common.
Extremely common, yes, up to 42% prevalence in some series, primarily caused by the chronic inflammation itself, but also significantly exacerbated by the prolonged corticosteroid use needed to treat the disease.
Is surgery straightforward?
It's definitely a high-stakes procedure in a VKH eye. The absolute requirement is that the eye must be completely inflammation-free, totally quiet for a minimum of 3 months, preferably longer, before attempting surgery.
Why is that so critical?
Because operating on an inflamed eye, or even a recently inflamed eye, risks triggering a massive postoperative inflammatory rebound, which can be devastating. So rigorous perioperative anti-inflammatory management is mandatory. This usually means boosting the systemic immunosuppression around the time of surgery, maybe adding short-term oral steroids or steroid injections near the eye.
And the surgery itself.
Modern phacoemulsification with implantation of an intraocular lens, IOL, is generally safe and effective when done under these strict conditions. But there can be technical challenges, like dealing with those posterior synechiae or inflammatory membranes, which might require special instruments or techniques. After surgery, posterior capsule opacification clouding behind the lens implant is common and often needs a quick Y laser procedure later. But the final visual outcome is often limited not by the cataract surgery itself, but by any pre-existing damage to the retina or choroid from the VKH.
One more complication, choroidal neovascularization, CNV?
Yes, CNV. This is less frequent than cataracts or glaucoma, but it's a serious threat to central vision. It's the growth of abnormal new blood vessels from the choroid underneath the retina.
What causes it?
It's thought to be driven by the sustained chronic inflammation and perhaps resulting ischemia or lack of oxygen, which stimulates the production of vascular endothelial growth factor, VEGF, a signal for new blood vessel growth. These new vessels are leaky and fragile, causing fluid and blood to accumulate under or within the retina, damaging photoreceptors.
How is CNV treated in VKH?
It requires a two-pronged approach. First, you absolutely must continue aggressive control of the underlying intraocular inflammation with systemic immunosuppressive therapy. You have to treat the root cause.
And second,
You directly target the abnormal blood vessels themselves using intravitreal injections of anti-VEGF agents, drugs like bevacizumab or ranibizumab injected directly into the eye. Often, the best results come from a combination: systemic immunosuppression to control the VKH, plus anti-VEGF injections to shut down the CNV, sometimes with intravitreal or regional corticosteroids added as well. This approach can effectively cause the CNV to regress and often improves vision.
that covers a lot of the challenges. What about the overall outlook, the prognosis? You mentioned it's improved.
It really has, significantly. With modern approaches, early diagnosis, aggressive and sustained immunosuppression, often with early combination therapy, the overall visual prognosis for most patients with VKH is actually quite good. Many, if not most, can maintain good long-term vision, say 20/40 or better, if treated appropriately.
But there are still factors that predict a worse outcome.
Yes, several negative prognostic factors have been identified. These include older age at onset, having poor initial visual acuity, like 2200 or worse, or existing ocular complications when first diagnosed.
And delays in treatment.
A huge factor.
Okay.
A longer delay between when symptoms start and when treatment is initiated is consistently linked to worse outcomes. Also, as we've stressed, tapering systemic corticosteroids too quickly is a major risk for relapse and poorer prognosis, and simply progressing to the chronic recurrence stage generally signals a tougher course.
Are there imaging markers?
Yes, OCT findings like disruption of the photoreceptor layers, specifically the Isis junction or ellipsoid zone, at baseline often correlate with poorer final vision. Higher RPE reflectivity on OCT has also been linked to worse outcomes.
And positive factors. What predicts a better outcome?
Essentially, at the flip side, good initial visual acuity, early diagnosis, and prompt aggressive therapy, and a longer duration of that initial systemic corticosteroid therapy, maybe more than 9 months, with that very slow taper we keep mentioning.
We talked briefly about VKH in children. Can we revisit that? It's less common but more severe.
That seems to be the case, yes. While VKH is primarily an adult disease, it does occur in the pediatric population. And when it does, it generally tends to be more aggressive, more protracted, meaning it lasts longer, and unfortunately is associated with a higher incidence of long-term complications like cataracts, glaucoma, and that subretinal fibrosis scarring.
So a tougher course for kids.
Often, yes. However, despite this typically more severe nature, the visual prognosis for children with VKH can still be favorable if treatment is initiated early and managed aggressively.
So timing is even more critical.
It appears to be an even more powerful predictor in children. That interval between symptom onset and starting treatment seems particularly crucial for the final visual outcome in pediatric VKH.
Is the treatment approach different?
The fundamental principles are the same as in adults: control the inflammation quickly and keep it controlled. However, there's often a lower threshold for starting steroid-sparing IMT early in children. The goal is to minimize the total cumulative dose and duration of corticosteroids to avoid or lessen their significant long-term side effects on a developing child, such as growth retardation.
Okay, so summing up this deep dive, it feels like our whole approach to VKH has really undergone a major evolution.
It really has. On the diagnostic front, tools like ICGA and EDI-OCT have revolutionized our ability to see the underlying choroiditis early, objectively, even before those classic late signs develop. That's huge.
And treatment, too, moving away from just reacting.
Absolutely. The paradigm has shifted from a stepwise reactive approach to a proactive strategy, often using combined immunosuppression right from the start for significant disease. It's a different philosophy. The goal isn't just managing flare-ups anymore. It's intervening early and decisively to try and fundamentally alter the disease's natural history to prevent it from becoming chronic in the first place.
But there are still gaps in our knowledge, areas needing more research.
Oh, definitely. Despite the progress, challenges remain. We still need better standardization of treatment protocols. What's the truly optimal first-line IMT? What's the best dose? How long should treatment really continue? We need large-scale prospective randomized controlled trials to answer these questions with more certainty.
And biomarkers, ways to predict course or guide treatment.
That's a major unmet need. Reliable biomarkers, maybe from imaging, maybe serological markers in the blood, maybe refined genetic markers that could accurately predict who's likely to have a severe course, who's at high risk of relapse, and critically, who can safely taper off therapy and when. That would allow for much more personalized treatment.
What about new drug targets?
As we understand the molecular pathways better, like that IL-23, IL-17 axis, or the role of B cells in chronic disease, it opens the door for developing more targeted therapies. The hope is for treatments that are just as effective but more specific, with fewer broad immunosuppressive side effects. And one really exciting, kind of newer area is the role of the microbiome.
The gut bacteria, how could that be involved?
Well, the microbiome plays a huge role in educating and regulating our immune system. So, investigating whether the composition of gut microbes differs in VKH patients compared to healthy individuals could offer really novel insights into potential environmental triggers or modulating factors, and maybe, down the line, lead to new interventions like specific dietary changes or probiotics. It's an active area of research for many autoimmune conditions.
So, as you reflect on this deep dive, perhaps consider how medical understanding isn't static. It's not just about putting a name to a disease.
No, it's about constantly refining how we intervene, and crucially, when. It's that shift from just managing symptoms day to day towards trying to fundamentally alter a disease's long-term destiny. And how even seemingly small details, a hint of a new biomarker, a new insight into immune pathways, maybe even something about our gut microbes, could potentially change everything in the ongoing quest for better treatments and better health.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.